NEOBLADDER by none other than Dr. MIHIR Desai, sir. And I would like to invite Dr. Eric Menderson, Dr. Ravi Mohan Awardi, Dr. P.P. Rao, sir, Dr. Shrenik Shah, Dr. Hemang Bakshi, Dr. Kamlesh Patel, sir, and Dr. Jayant Patel.
Thank you very much again for the opportunity to present, and you've seen a kind of a male cystectomy that Dr. Anup showed very well laparoscopically. So today, in this cystectomy talk, what I'd like to do is, firstly, come up. I'm not going to belabor too much of the scientific data, but just some summary data, because unlike many of our robotic oncologic procedures, now we do have 8 randomized trials between robotic and open radical cystectomy that do give us some messages that are fairly clear cut, and we don't have to imagine. The main thing I'd like to focus after I do a little technique on the male and female cystectomy. I'm just going to give you some salient points, but focus more on the diversion, and then if time permitting, we'll do a little bit on the intracorporeal Indiana pouch. As far as radical cystectomy goes in 2025, truly there is no contraindication to doing a cystectomy robotically. So any patient that is a candidate for a radical cystectomy is a candidate for a robotic radical cystectomy. Tumor stage does not matter. Even as standard of care now, most of these patients get neoadjuvant chemotherapy. I think we are seeing a transition of shift from cisplatin-based chemotherapy to enfortumab, pembrolizumab combinations, which are way more effective. We're really looking forward to those data maturing in the neoadjuvant setting. Previous abdominal surgery, obesity are relative, and in fact I would say prior pelvic radiation and prior prostatectomy, doing these robotically is actually easier than doing them open surgically, because the access to the prerectal space, I think, is much superior with robotic magnification. In terms of the cystectomy part of the operation, all technical complexities can be achieved. Nerve sparing in men, female organ sparing in females. As far as lymphadenectomy goes, this used to be something that was done based on individual preference, but there is no anatomic template in the pelvis that is not accessible robotically. But now, and in fact, this is data from the Memorial Sloan Kettering randomized trial that showed the robotic group actually had a higher percent of extended node dissections than open. So which doesn't mean you cannot do extended node dissections open surgically. It just means it's a surgeon's preference thing. The most important study from a cancer standpoint came up with the multi-center RAZOR trial, and this was a trial that was powered primarily for an oncologic outcome that at 2 years did not show any difference in recurrence-free survival. Jim Cato's UK study, again not powered for oncologic outcomes, still also showed similar cancer-specific and all-cause mortality. Moving to the diversion philosophy, you saw, in the laparoscopic days, I was actually part of the team at Cleveland where we did the first intracorporeal series on cystectomies, both with conduits and neobladders. The time taken, efficiency, complications are very high. This was actually, so therefore doing these extracorporeally made sense. But now with the robotics, I think the trend is changing. Certainly conduits are now all being done intracorporeally, but if you do have volume, neobladders can also be done. We've performed and reported all variants of intracorporeal diversion, including continent cutaneous. I'll share with you a little bit of our technique at the end, but this is probably the one diversion where extracorporeally it makes more sense, which is Indiana pouch, because once you've mobilized the colon robotically, doing the pouch through a tiny paraumbilical incision is fairly easy. You don't have to do the urethral anastomosis part, which is what takes up, which makes sense. And the right colon pouch, even if you do it intracorporeally, you have to change the position of the patient completely, and so it does break the flow of the operation. Just kind of going at the main, I just want to showcase a few of the comparison differences. Now the Memorial trial really didn't make sense because it was powered for a perioperative morbidity difference, and since the diversion in both these arms were done, open surgically, it was an extracorporeal diversion, you wouldn't expect any differences. Similarly, the RAZOR trial also did not show any difference in, or a very minor trend in favor of robotics in terms of perioperative recovery. But again, all diversions here were performed, extracorporeally. The only trial that could really assess perioperative morbidity differences was the UK NHS trial, which actually had a completely intracorporeal technique in the robotic arm compared to open surgery. And they did show a statistically significant time out of the hospital in favor of robotics for the first 90 days. It wasn't just the index hospitalization. They also calculated all readmission days in the first 90 days and showed that robotics had benefits. But I think the most important difference in my mind was the significant difference in, not surprisingly, wound, but I was surprised at the magnitude of difference between thromboembolic events. Now remember, in the NHS trial, all patients undergoing the trial had the exact same clinical care pathway for DVT prevention in terms of thromboprophylaxis measures. And so even with standardized clinical care pathways, the difference was 8.3 versus 1.9%, which is a significant difference. And they actually looked at, and I'm not going to go into the details of these, 5 different measures of quality of life, and they measured it early, 5 weeks, 12 weeks, and at 3 months, and found a benefit in favor of robotics at the 5 and 12 week mark in most of these outcomes. A lot of the trials measure quality of life at 6 months or 1 year. You don't expect a surgical approach based difference to last that long. At 1 year, quality of life is defined by cancer recurrence, need for chemotherapy, etc., and not by whether you did a surgery open or robotic. But they did measure it early and found a difference. So now I think the debate is sealed. Basically, the oncologic outcomes are the same. There is blood loss benefit, there is length of stay benefit, there is thromboembolism benefit, there is wound benefit, and a quality of life in the early phase. Now, I'm going to now shift gears to diversion part, and I'm going to talk primarily about an orthotopic neobladder, because all the steps of an ileal conduit are automatically included in the orthotopic neobladder. You do the bowel work, you plug in the ureters, and so there is nothing separate. When we started our intracorporeal program, we prefer to do a standard Studer type neobladder, just because this has been probably studied the longest, and the long-term functional outcomes in terms of at least the urinary function have been confirmed. So while many people do variations, why neobladders, etc., that may make the robotic technique more efficient, we feel that sticking to the standard neobladder helps. And I'd like to take this minute to actually recognize and remember Professor Studer, who, as most of us know, passed away last year. And just about a month ago, Don Skinner, who built our program at USC, also died. So the urology world lost 2 of the leaders in bladder cancer, at least the surgical therapy that defined the field for the last 3 to 4 decades. But this is what you want to do at the end. You want a spherical, low pressure system with a good capacity. And that's what our typical Studer cystograms look like at the time of Foley removal. And so you want a spherical pouch in there. We also did do a limited study with urodynamics that showed again that this conferred to what we would expect. A brief slides about enhanced recovery pathways. These are clinical care pathways to standardize recovery, and they begin before surgery, continue intraoperatively and postoperatively. It has multiple components, but the strategy should be that this is not an alternative to doing something robotically. It should be added to any cystectomy program to reduce the morbidity. So now, with this in mind, I'm going to pause here for a bit. So the male cystectomy, this is a video that we did where the left side, the tumor was predominantly right-sided. This patient wanted nerve sparing, so we actually did a nerve sparing on the left side, did a wide excision on the right side. So one point I'd like to make is my preference for cystectomies is the posterior dissection should be the first step of the operation after the ureters have been defined. And I do like to preserve the ureters till the end. It gives me anatomy, bearing, and I like the idea that you can keep the urinary obstruction to a minimum, and we do think that it reduces the risk of or the magnitude of postoperative AKI. But the first step, once you've identified the ureters, is to join those 2 urethral peritoneal incisions in the cul-de-sac and find this prerectal space. Actually, so I'm going to start this video again. So, and the fourth arm is retracting the bladder up, and the assistant pulls the sigmoid back so that you get very good traction. And doing this at the beginning of the operation when the bladder is still suspended gives you a beautiful exposure of the prerectal space. Make sure the ureters and seminal vesicles are up top. Sometimes you can actually get into the space between the SVs and the bladder. And then I use the 30-degree up on the robotic system, where you can really go all the way distal to the prostatic apex. Now, the next step is very important. Once this is done, I make a window medial to the obliterated umbilical ligament and lateral to the prostatic the bladder pedicles, going all the way distally. And for a nerve sparing, you need to preserve all the tissues lateral to the seminal vesicles. And so what I do is I clip this and cut, so you preserve a lot more tissue, and this dissection goes down all the way up to the prostatic pedicle. So we've reached the prostatic pedicle. Now we've dropped the bladder, and then you can really be intrafascial on the prostate, because again, you're not doing this for prostate cancer. And if you really want to do a good nerve sparing, you can see here the nerve has been released all the way nicely up to the apex. So this is kind of the way you would do a nerve sparing procedure. And now this is one of the last clips, and I don't open the endopelvic fascia as you saw in my prostate today. I do the same thing in bladders if I'm doing a nerve sparing. And here the nerve is now released. You can go as high as you want. Now on the other side, because of the bulky disease, I go all the way down flush to the rectal wall, and I use this vessel sealer, which is exactly like a ligature. You make small packets and you do a double seal, so this gets all these vessels sealed very nicely. The only vessel I actually clip is the obliterated umbilical. The remaining vessels are smaller, and you can get a very nice seal. And I actually feel personally this is cleaner than a stapler. Stapler lines often bleed through the staple lines, but this stays very good. And I like the fact that you have an endorist, but you can see here you preserve all the tissue on the left side, but on the right side everything has been removed flush to the prerectal fat. So that's the difference between a nerve sparing and a non-nerve sparing. And you can see where all those clips are on the left side. Your nerve sparing begins at the level of the bladder pedicles, not at the level of the prostate pedicle. So if you don't preserve the nerves there, preserving it distally in the cavernosal area does not make any difference. So this is kind of the technique for cystectomy in the male as far as nerve sparing goes. Now, in the female, anterior exentration is straightforward. I take the obliterated umbilical ligaments, and then you basically start taking all the branches of the hypogastric on both the sides. Then I take the stay stitch that anchors all the female pelvic organs. You hit it through the uterus and suspend it so that you get a very good exposure of the fornix of the vagina. And so you basically have a sponge stick in the vagina, and you cut over the sponge stick, and then you carry the vaginal incision parallel, and then this guides you as to which level to secure the perivesical tissues. And then the vaginal incision is carried down all the way below, and then similarly you keep taking these paravaginal bleeders. And this was an older video where I took clips, but nowadays I would take a vessel sealer, and then you would go all the way down distally. And as soon as you reach the level of the distal vagina, again the vessel sealer here helps quite a bit to maintain pneumo. And as soon as you reach all the way down, then I deliver the Foley catheter into the field, and using the Foley catheter end that is going into the urethra as a guide, you can actually excise the entire urethra from above. Now the important part is to leave a lip of the vaginal wall that you can suture nicely at the end. So this is the entire urethra being disconnected. You go back and forth, and then the entire specimen can be entrapped by a bag that is introduced from the vagina, and then once it is entrapped, you can then take it down and then extract it from the vaginal wall. And then you basically suture this with a V-lock, but make sure you get the vaginal mucosa, otherwise it can retract. Female organ sparing, I think, is increasing in popularity because the incidence of direct invasion to the female organs is actually fairly low. In fact, most patients who are candidates for orthotopic neobladder, you should try and do a organ sparing procedure to help suspend the neobladder appropriately in the in the pelvis, and also to preserve sexual function. So if you have a large posterior trigonal tumor, etc., those are the ones where you should not do an organ sparing. You should do an anterior exent and then reconstruct the vagina there. So this is a patient actually who had a nephrouretrectomy on one side. And so basically the plan is to first identify the ureter above and then below the broad ligament. And so you tug on the ureter, find out where it is below the uterines, and then once you find the ureter there, then you can start taking the superior vesicle pedicles. And you have to preserve the uterines obviously because we are preserving the uterus here. And then you carry the incision in the space between the bladder base and the uterus, similar to what actually Dr. Ramlingam was doing today. And this plane has to open up nicely. If it doesn't open nicely or it's stuck, you're better off again excising a little strip of the vaginal wall. And the other thing is, don't go too distally. The female bladder neck is much more cephalad in orientation than you would think, and so you don't want to devascularize the posterior part of the urethra. So this is only about a couple of inches, and the sponge stick actually helps. This again identifies the paravaginal tissues. Now at this point I will divide the ureter. This patient actually had a stent in there, and so we excised that, removed that stent. And then using that stent and the ureter as a guide, it tells you where the bladder base is. We would take all this, paravaginal tissues, all the way down. And once you're at a certain level distally, then you start dropping down the bladder. And again, now you drop down the bladder, and then at this point we get to the bladder neck. As you see here, the bladder neck is way more cephalad than you think, and you must make sure that you don't dissect beyond this bladder neck. The female urethra is short, and if you excessively dissect around the urethra, then you will devascularize it and denervate it. And so we take a bladder neck specimen, and then an important thing with this is you want to take a kind of a omental flap, and so you base it off the right gastroepiploic. So you basically hold the left margin of the greater omentum and make windows and start releasing it. Now again, nowadays this part we would do with a vessel sealer, not with clips, but you can do it with any energy. I think the vessel sealer is the best way for mesenteric and omental vessels, and you keep elongating it. You see the uterus nicely suspending in the pelvis, so the bladder will lie on this, and you want to do it enough that this omental flap reaches down there without any tension at all. We secure it to the edges of the vaginal incision, and then this way you have complete covering of the vagina. Because remember, you can cause micro traumas to the vagina, and you can still get neobladder fistulas even though you've not formally opened the anterior vaginal wall. I'm going to now go on to the intracorporeal diversion. Just to, in interest of time, I think the most important aspect of a intracorporeal orthotopic neobladder is time efficiency. That's the most important. It's not a technically difficult operation. It's just hard to do it fast. And I think there is no magic step that makes it go fast other than everybody in your team knowing exactly what the next step is. Remember, this procedure has 100 small steps. So if every step takes even 1 minute longer, you are 2 hours delayed in the case. So every stitch, if it has to be opened, if it has to be cut, stapler has to be opened, and you'll almost never find the nurse in the room when you want that suture. So these things have to be, they're the same exact number of sutures and staplers and equipment that are required. And what I do is I verbalize my next step. I'll always tell them what is the next thing I need, and that will actually keep the operation moving. The only technical part I would say is keep the suture length short. I use a V-lock. I like to use a 6-inch V-lock. It is better to have multiple short sutures. It is much faster suturing that way than few long sutures, because the time taken to pull the suture through is what takes time in suturing. And so that's why you want to have short suture lengths. The ureteroileal anastomosis not coming down is another question asked. The most important part, I think, is before you do the diversion, take the patient almost completely out of Trendelenburg, because if the bowels are going to be moving and going towards the head, all bowel handling becomes more tricky. And you really don't need that much of T-Berg for the diversion part. Secondly, make sure you identify a mobile loop of ileum, mark out your point of urethral anastomosis and then measure out the bowel segments. I think that's an important part. Thirdly, if you feel that that bowel segment that you've picked is going to be a little hard to reach, take 5 minutes to dissect out the terminal ileum and the cecum from the retroperitoneum. People who have done RPLNDs will know that you can actually dissect this off the posterior retroperitoneum quite high, and you will gain. And basically what you're trying to get is 1 or 2 inches of additional mobility. You don't need too much more. It just is that 1 or 2 extra inches that makes a difficult, tight anastomosis a little more user-friendly anastomosis. Thirdly, we do take a Rocco stitch equivalent to fix the posterior plate at the site of the urethra so that it is not going up by any kind of gravity. And lastly, unlike my bladder where I use a braided suture for the anastomosis, for my neobladders I always use monofilament sutures because this allows me to take 4 or 5 stitches and I can parachute it down if it is tight rather than having to tighten it each time. And thirdly, the bowel wall, especially the ileum, is very unforgiving with braided suture if it's under tension. Those suture holes become bigger, it shreds more, and so monocryl is much more forgiving. Lastly, before I show you the video clips, I wanted to just explain the measurement and how we map out the Studer segment. So the first point, as I said, is we find a mobile loop of ileum, and that's the 11 centimeter point. That marks the point of where the urethroileal anastomosis is going to be, and that's the step 1 in this operation. Once we define that point, we mark it with that Rocco stitch, and then we measure out 11 centimeters towards the ileocecal junction. That gives us our 0 centimeter point. Now, the measurement is done by a pre-measured 11 centimeter stitch with a WEC clip at the end. So it's almost like a rescue stitch measured at 11 centimeters, and that is first passed at that 11 centimeter point, and then you rotate it towards the ileocecal junction, disconnect the ureter there, then you take the same stitch now away from the ileocecal junction, and you mark out 22 centimeter point. That is marked with a stay suture. Now, what we do is we color code our stay sutures. All stay sutures on this isolated limb are going to be undyed, and the 2 stay sutures on the ileal segment that we have to anastomose are going to be dyed, so that way you don't get confused. Part of the time lost is if you get confused, the only way you can get unconfused is to again trace the entire bowel loop towards the ileocecal junction, and you're going to spend a lot of time more. So make sure you do this right then and there, and then that first 22 centimeter that we measured out is matched to an equal 22 centimeters on the other side to give us our 44 centimeter point, again marked with a stitch, and then you eyeball about a 10 centimeter afferent limb, and your neobladder is done. So this is the segment where we find a mobile loop. I first take my Rocco stitch right then and there so that I don't have to put that at the end. And then this is that measured 11 centimeter stitch, and then you measure out again towards the ileocecal junction. Now I prefer the assistant to come in with the staple, and all these staple loads come from the lateral port. And I'm going to tell you, I'm going to have a few slides to show you the stapler orientation. Then we take a second fire into the mesentery, and then that 11 centimeter limb that we have first, we measure it to another parallel 11 centimeter, that is the 22 centimeter point. Again, it's an undyed stitch, and then the fourth arm holds that 22 centimeter point, and we measure out another 22 centimeters on the left limb to make the 44 centimeters. So that marks the end of our the reservoir, and then we eyeball about a 10-12 centimeter afferent limb. Remember, in an intracorporeal diversion, you don't need a very long afferent limb. The ureters are right there. It just is a short segment. You should not make it extra long. And we put a blue stay suture there to mark it out. What we do is proximally, instead of going deep into the mesentery, we excise a 10 centimeter piece of ileum, which is called our discard segment. So you don't have to get 2 deep mesenteric divisions proximally and distally. That's a kind of a USC technique. Then we go up to the small bowel anastomosis. So you cut off a little corner of the small bowel edge at the anti-mesenteric edge, and you have those 2 blue stay sutures on the mesenteric side. Those will help with traction too. So these are excised, and now the assistant comes in with the stapler from the lateral port, and you basically feed these like you feed a trouser on a leg, and pull it all the way in. Then the second segment comes in. Make sure that those stitches are outside, so that keeps the mesentery outside from your stapler limb. And once you feed the second limb up, make sure it's all the way back. Then ask your assistant to lift up the stapler before they close it, and then you close and fire. I take two fires of a 6 centimeter load. And the reason I do this is that allows me to take a very generous donut off the top. Remember, any watershed ischemia is going to be at the edge of the bowel. So if your horizontal firing is deep into the bowel, then the chances of ischemia at the edge are very low. So at this point, we take off those two blue stay sutures. Because if you take this vicarial stitch into a staple load, it has a purse string effect. So you don't want this sitting there. So I take this out, and then we come up with, now the only time we come in through the medial port or the air seal port is for this horizontal firing. So again, you lift up the bowel edges, line it up nicely, and now the stapler will come in from the medial port. And then you take, as I said, a very generous horizontal fire off the top. And now that we have a 12 centimeter side-to-side anastomosis, you don't have to worry about this. So it's a good inch off the top. And this way, if there is any edge ischemia, it is that segment is excised. And so that's your anastomosis being done. And now you detubularize the bowel. And one of the things that helps with that detubularization is to use a chest tube. So we put a 40 French chest tube inside the bowel, so you can incise this on top of it. Don't worry about using cautery. If you try to cut this cold, you spend so much time coagulating at the end. It's better to just use cautery the first time around. Make sure you don't buttonhole the posterior wall. That's going to be difficult to find out and difficult to fix at the end. Once this is detubularized, then you want to arrange both the parallel limbs and create a posterior plate, such as this. And this is done by a series of stay sutures, and you want to start from the proximal end and go distally so that there is no unequal limbs. And each stay suture acts as a counter traction point. So the assistant pulls the proximal stay suture towards the head, and the fourth arm pulls the distal suture towards the feet. So this, between these two, each segment of this stay suture, you get a nice apposition of the bowel edges. So all this facilitates your suturing. So this is the most distal one, and you'll see that we then use the fourth arm to hold that. And as you give traction and counter traction, both edges get aligned nicely. Again, you want to make sure for this posterior plate that you take the bites up perfectly, because if this cuts through and if you get a leak posteriorly after you've anastomosed it, it's extremely difficult to fix. And remember, neobladder leaks take a very long time to seal. There is no perivesical fat to plug these holes. It'll keep leaking for a fairly long time. So make sure that you take your time and make sure that this is a nice watertight, secure anastomosis. So this is all done till you come up proximally. Now what you do is you rotate this posterior plate anti-clockwise such that the 11 centimeter point that we had marked out now is adjacent to the urethra, and that's how, and then you can basically fold the 0 to the 44 point. That gives you a cross folding. So this is you find that Rocco stitch that you had, and that's the easiest way. So we've rotated this plate anti-clockwise, then you get this down all the way, and then you take it through the rector urethralis so that the plate stays in place. Remember, this doesn't have to completely approximate, it just has to keep the bowel loop in position so that it doesn't keep sliding up. Because you still have about 5 to 10 degrees of T-Berg. And you can take an additional suture from the rector urethralis to the serosa of the bowel to just make sure that it's got a nice, broad, secure look. And now we start the urethrovesical anastomosis using a double arm monocryl stitch. And then this is then carried down. Take it slow. These sutures are friable and you don't want them snapping or breaking. Then you have to redo the whole thing again. So, and then what I use is a 24 French Rouge hematuria catheter. This is a plastic catheter which has a very large end hole, And so with this, you are protected against mucus plugging, and you then do not need, if you use this catheter, you do not need a suprapubic tube. And that really helps with the robotic diversion. So none of our robotic or open cystectomies, neobladders, get a SP catheter. They only get this single urethral Rouge hematuria catheter. And it works beautifully in terms of irrigating out mucus, and which we start irrigating from day one. So this is the anastomosis that has been complete. And then now you take a series of stay sutures anteriorly. Make sure you invert the mucosa. Part of that, very superior part of that anterior suture line is better done from the inside, because otherwise it is very difficult to do from the outside. The same thing you do, 6 centimeter sutures that you take. Make sure you get the serosa, and then the suturing is done. And the same thing with these stay sutures, they act as traction, counter traction points, and then that's the end. That's the junction of where the afferent limb is. And you can see here, try to take only seromuscular bites so that you invaginate the mucosa. This also prevents leaks and adhesions of bowel loops there at that site. And this gives you a nice closure all the way to the end. Now the urethral anastomosis, we first take a ICG injection at this point. This is very, very helpful. So when you inject ICG now, you can check the vascularity of 3 things. One is the ureters, and excise anything that is not nicely lighting up. Second is the isolated limb, in this case a neobladder, and third would be your bowel anastomosis. So this particular video was taken from a ileal conduit case. So we check the vascularity of the ureters. We'll now look at the vascularity of the ileal conduit that you see lying right next to it there. And then you also look at the vascularity of the anastomosis. So that's very, very helpful to confirm the vascularity of all these 3 things. That you can see area green and perfused. And then for the urethral anastomosis, we do a Bricker technique. Now, for the last 2 months, we are doing all our anastomosis stentless. And there has been no increased leak of strictures or urine leaks, but there has been a significant reduction in the incidence of pyelonephritis postoperatively. So, but historically, what we did was, after spatulating the anastomosis, I would take a 4-0 vicryl, do a continuous, but take 2 separate sutures for the anterior and posterior wall. And once you're halfway through the anastomosis, if you do like to stent, over a glide wire, you should put a double J stent. Put a long one, 30 centimeters. So what happens is, by the time it's time to take the stent out, these typically gravitate down towards the bladder neck, and you don't have to fish it up the afferent limb. But all we do is excise that patch of the ureter, and then the remaining ureter anastomosis is then done in a continuous manner. Make sure there are no leaks here, and it is very tight, watertight. If the ureter is thin or it's radiated or you have any doubts, you can always stent. But if it's a nice, robust, dilated, thick-walled ureter, then you can do it stentless, and it's fairly safe. And then we kind of undersew the staple line and make sure that you exclude the staple from the neobladder. And finally, make sure you fill the neobladder. I hope this video works. But you do want to fill the neobladder to make sure that there is no leak, and fill it up nicely, because any leak now, take your time to fix it, because as I said, this is a very free floating structure. There is nothing to cover it, and these leaks take a long time to heal. Usually we take out a Foley catheter after 3 weeks after a cystogram, and a week later the stents come out cystoscopically. So now, one question about the stapling. Now, you will see we staple through this lateral port, except for the final stage of the anastomosis that comes through this medial port. But some people prefer to put a suprapubic catheter. They feel it's easier to get a right angle at the mesentery coming down 90 degrees. But the one problem coming through a suprapubic area is length. Remember, the distance from the tip of a suprapubic port to your bowel, if you've lifted it up, is very, very short. There is not even enough space for the stapler to go in, open, or articulate. While if you have your stapler coming in from the lateral port, you have this much of room to put your stapler in, so you have an adequate amount of length. And so I think that that is a problem because remember, if you put a suprapubic tube and your suprapubic port and your bowel loop is here, you just don't have enough space. So it theoretically sounds good, but practically it's not really helpful. The other things to look for bowel anastomosis is that no instrument is atraumatic. Even cardiac forceps, and I'll show you a video, they can cause serosal tears. Orientation is key. I told you about the color-coded stay sutures. And be mindful of other things. I mean, it is so easy to include another bowel loop in your stapler. I have done it twice, where every time it's felt, this is perfect, there is nothing close to it, and always check your vascularity. Now, talking about the cardiacs versus the bowel forceps, I'm hoping this video works well. Okay, so this is the cardia being used. I would never grab a bowel loop like this, full thickness, and you'll see this here as you're examining it, where that we saw that area. If you can see that where the cardia held, it's completely taken a bite out of that serosa there. So that's a full serosal tear. You can see mucosa there pouting out. And so these cardias are not atraumatic. And so, you know, we had to suture this back. This is another stapler. So remember we were doing the two side-to-side staple loads. So this is one being put in. The first one, no problem there. So we put in, you know, fed in both. This is actually during a live surgery case at USC, by the way. And as Murphy's Law has it, somebody asked me, why do you need a second staple load? I said, oh, because I get a wide anastomosis, it's no problem. And sure enough, I put the second load. It all seems to be going nicely. And then we fire it, so it all looks good. We have it all the way in. It's all the way back. Looks good. Fire it. I just need another 5 centimeter long. And once it's fired and I take it out, it so happens that one limb went inside the lumen and the other limb was actually outside the lumen. So it actually divided all that I had stapled the first time next to it. So we had to resect that whatever I had stapled and I had to redo the full anastomosis again. So this is another thing to keep in mind, that it takes 1 second. All you have to do is make sure that it's in, and otherwise you have to then redo the whole thing again. This is another case that after you're done with the anastomosis, always check things even if everything seems to be going well. So this was, I think, a case given to me by Rene. And so you do that, you do the side thing. He didn't look at the back. I almost always have the assistant rotate the staple to look at the back side of the stapler. And so they did this. It all looked good. That was fired. And then as part of habit, they kind of just check to make sure that the front and the back of the stapled segment all look good. And then as they were, so this is taken out. So as they were looking, you can see down here, another bowel loop was included. This was not during the stapling, this was during the mesenteric division. See this? This is included in part of the mesenteric division. So they had to then, release that. But it wasn't a very small, big segment, so they were able to just excise this and then suture that thing closed. But again, this is something that you have to, if they had not looked, this would have been a problem down the road. So they just excised it fresh and then they sutured it together. This was another case where this was you see how the staple comes in from the top at 90 degree? I mean, this one had good length, but typically you don't. And there is bleeding inside on the staple line. Remember, staple lines can bleed. So if you see something coming in from inside, make sure you fix it now. Otherwise, these things tend to bleed. It'll cause them melena. It's a big problem to fix later on. So take a stitch and make sure that you have that staple line visualized. So always look at the inside of the staple line. And last one, there are other things such as in this case, a ureter had gotten stapled into the staple line. So it's a long redundant ureter, so it's in there. Fortunately, we have a lot more ureter length than we need, so it's not as bad as the bowel, but you need to still be careful and make sure you don't include these. I think we just have 2 minutes left, so in the interest of time, I'm going to stop here and happy to take any questions.
MIHIR, Yeah, here.
Yes.
One thing like we have been using the external stent 75 centimeter long and keeping it out. And that's we have seen helps us in post-operative recovery is better. Every urine is draining outside and only one periurethral catheter and we remove around 3 weeks time. And so we have seen that since we changed to the external stent, the life has become easier. So, and second question was, uh, we have not been using the discard segment. So how does this discard segment helps in?
Yeah, so regarding the external stent, the only problem with the neobladder is that it's a very cumbersome process to exteriorize that stent. So that's why we used to use it in our first 12, 15 cases and then we stopped. About the discard segment, what happens is you need mesenteric mobility, right? So traditionally what you do is you go perpendicular to the mesentery in an avascular space and try to go deep so that you get a separation of your bowel anastomosis from the isolated segment, whether it's the conduit or the neobladder. Now, if you were to go deep both distally and proximally, say for a conduit, you could end up having a very narrow base and therefore worrying about ischemia. So what happens with the discard segment theory is your distal incision goes in the conventional way, it goes deep down. But proximally, instead of going deep, you're going horizontal parallel to the bowel wall. So you're devascularizing, say, a 5-7 centimeter piece of bowel, but you get the bowel end separated from your isolated limb by that horizontal separation. So it just keeps the anastomosis away, but it's not by going deep, it's by going horizontally.
Mihir,
Yes.
excellent presentation. I have one question. Just here.
Okay, yes.
In female patients, if we do a neobladder, then chances, how many chances of incontinence?
So very, very good question. So female neobladders are very tricky. The bigger problem is not as much, so their true incontinence risk is, if you do this and if you don't devascularize the urethra, is not terrible. The problem is they do become hypercontinent because of the prolapse. So when they become hypercontinent, they start retaining urine. And when they start retaining urine, they start developing a little bit of an overflow incontinence. If you correct, and some of them will actually start developing a prolapse, which is actually quite tricky to manage. So if you reduce the prolapse by, say, a pessary, then their emptying improves, or if they start self-catheterizing, their emptying improves and their incontinence actually goes away. But I would say they still have about a 20-30% nocturnal incontinence risk and about a 5 to 10% daytime incontinence risks.
Because I had done only 2, and out of that, in one patient is completely incontinent and did a total anterior pelvic exentration and neobladder. So I went in the literature for next patient, and in next patient I had kept the uterus. And that patient also nocturnal incontinence is there. That's why.
So nocturnal
is
they
there
will
any
get
extra steps
See,
or precaution we can take while during cystectomy?
No, the problem and the reason for nocturnal incontinence is that you don't have the neurogenic feedback loop. So as your normal bladder fills up, your sphincter tone should go up, which doesn't happen. So that's why they will always leak at a certain point, even men. So it's nothing to do with their sphincter. It's nothing you can fix anatomically. The only thing you can do is make sure that your neobladder is of an adequate capacity. And if they can empty it out before it reaches the point of leakage, then you're okay. But you know, female patients are actually way more accepting of their incontinence than they are of hypercontinence. Men don't like the incontinence, but females are totally fine with it.
Sir, I want to make this comment for nighttime incontinence. Last 3 patients I have that I have started tablet MIHIR because MIHIR itself desmopressin and that we are giving for other causes, but it decreases the urine output. So for 4 or 5 times night frequency or incontinence that has been decreased tremendously and all 3 neobladder patients are quite fine. Though scientifically it is not proven, but I have started clinically. And that helps me a lot.
No, see, males, we actually have now at least 16, 17 patients who've elected to have a AUS put in for, and they only activate it at night for the nighttime incontinence, and they are happy. But unfortunately, you don't have a good AUS type option for female patients, and if you do anything like a sling, they become hypercontinent, and they'd much rather be leaking than catheterizing.
Yeah, thank you, Mihir.
Thank you.
It's an excellent presentation. Now we can move forward for the live surgeries.
Right, so we are now ready to present the next case, rather the last case for the day. Sir, your moderators are ready, sir? Auditorium?
Yes, we are ready.